Everyone. Welcome to the session. For the past, I would say, 6 years. We've been here 7 years, but for 6 years we had that session, the clinical and scientific update in kidney cancer, and it was the highest rated session. Despite you can see the program over the past 7 years changed, the program had a lot of edits, addition. That type of session stayed strong. And that session is about what happened in clinical and scientific, mostly translational and biomarker-related updates since the last meeting. And usually it involves updates during ASCO, ESMO, and ASCO GU and AACR. And we have a very diverse lineup of speakers here, starting by first-line metastatic RCC update with my colleague, Dave McDermott, across the street. David?
Thank you, Tony, and good morning, everyone. I'd like to thank the organizers for the opportunity to speak to you today. I'd also like to apologize to the organizers to start off because I thought I had 12 minutes to talk, and I don't, so I'm almost certainly going to go over. Hopefully I'll be invited back in the future. As Tony said, I'm here to talk about first-line therapy. Here are my disclosures. Dr. Rini helps us all out by every once in a while, summarizing on Twitter. Here now the final results of the first-line IO combinations, which are now the standard of care for our patients, those approaches that have led to dramatic improvements in long-term outcomes for our patients. I won't belabor all these details, but they're there for you if you'd like to review them. Let's talk, at least in the first part of my talk, I want to talk about how we've made so much progress in the last 10 or 15 years, but then spend most of the rest of the time talking about the future and how we can work together to produce even better outcomes and hopefully more cures for our patients in the future. So as most of you know, kidney cancer is thought to be an immunogenic tumor, which essentially means at the time that most of our patients are diagnosed, their immune systems have recognized the tumor as a threat and have filled the tumor with lots of immune cells. One of the key questions was, how do you get those immune cells to kill the tumor? About 10 years ago, Bob showed with the nivolumab second-line trial that PD-1 blockade could do that by reversing T-cell exhaustion, and that led to a new paradigm for our patients, which was essentially VEGF therapy in the front line and PD-1 therapy in the second line. We spent most of the last decade essentially bringing PD-1 earlier in the treatment paradigm for our patients, first in the metastatic setting and now the adjuvant setting, to good effect. But then the question was, how do you do better than just PD-1 alone? So in the time these trials of combinations were being discussed, people relied on animal models, which were fairly inadequate since, as most of you know, there's not a great immunocompetent mouse model for kidney cancer, or other tumor types. We're essentially borrowing ideas from other places. One of those ideas was, let's block VEGF along with PD-1 at the same time. There was preclinical evidence that suggests you could improve immune cell infiltration into the tumor by doing this. Some of the early phase 1 trials, particularly with atezo-bev, suggested that that was what was going on when you blocked both of them at the same time. And this was a randomized trial, the first, the PD-1 and VEGF, that sort of confirmed that benefit and showed real early endpoint improvements over the standard of care with overall response rate, progression-free survival, and encouraging early overall survival results. Interestingly, though, as we follow these trials out, and there have been several, all of which have shown the same early impact, the late impact has sort of faded as we got into 4 and 5 years, particularly in the favorable risk group. And this is sort of, at least in my opinion, somewhat of a cautionary tale. I think we need to try to understand why the patients you would predict would do best with VEGF blockade and survive from a survival point of view are doing no better, or in some cases maybe less well with combination VEGF and PD-1 blockade. It's certainly a cautionary tale for future combinations. But this has become the standard for most patients with metastatic disease. The other alternative was sort of borrowed from our colleagues in the melanoma world with CTLA-4 blockade. As you know, CTLA-4 is thought to help with immune cell priming and activation. And once again, Bob showed in 2018 that by combining PD-1 and CTLA-4, you could beat the prior standard of care sunitinib with early endpoints. but probably more important was the durable benefit that has shown up with this trial. Now we've looked at this, it seems like almost every 6 months, but now out to 8 years of follow-up, just recently presented this year, looking at PD-1 and CTLA-4, you see sort of the classic effect of an effective immune therapy. You see the same thing with IL-2 and with allogeneic stem cell transplant. You see tail of the curve benefits. You see that flattening of the plateau of the PFS curve. You see consistent overall survival even as you follow the patients out longer, which is encouraging for patients and for those advocates of immune therapy. However, it's not all positive. Obviously, when you combine immune therapies, when they're active, you also probably increase side effects significantly. And as Tien showed just a few weeks ago at ASCO in the Pedigree trial, there's significant toxicity with PD-1 and CTLA-4, probably more than we expected, with many patients dropping off that study because of tox. There were at least 15 patients who might have died of grade 5 toxicity. So this just suggests that we need to pick our patients carefully, and importantly, the people giving PD-1 and CTLA-4 need to be comfortable giving it. So this is my sort of general sense of the pluses and minuses of combination blockade. I won't belabor you with the debate. We actually thought the debate was going to be irrelevant because we thought triplets were going to be the thing. And as Bob and Toni looked at the triplet of Cabo, Ipi, Nivo, so essentially all effective mechanisms of targeting kidney cancer in one approach, once again, the early results encouraging from an efficacy standpoint with improvements in progression-free survival and response, but no improvement in overall survival and significant toxicity. That triplet has not moved forward. We have the LIGHTSPARK-012 trial, which may bring triplets to the frontline therapy, but we have to wait for those results. Hopefully we'll see those within the next year. But I think regardless of those results, at some level, I think this debate about what to do in the front line is probably a waste of our time. I think the more critical question is not what to give patients, but do you believe that advanced kidney cancer is curable? Sort of yes or no question. I think if you answer that question yes, then our first priority as a group should be to work together to make these cures that we see in some of our patients more common. I think we can all agree that the current therapies produce too few cures, and if you ask me, one approach to creating more of them will be trying to do more, trying to enhance the immune response to the tumor in more effective ways. Well, how do we do that? Well, I think that's through translational research, which is not just about identifying new targets for patients and understanding resistance pathways. It's also about learning better than we've learned so far about how to rationally apply these drugs to the right patients and at the right time. This is an example, I think, of effective translational research. This is work led by Sabina Signoretti and David Braun and Kathy Wu. What you're looking at here is an inflamed kidney tumor. Those aqua dots on the screen are immune cells within the tumor, and at the tumor margin, you see how so many of them are there. The essential question is, how do you take this immune inflamed portion of the tumor, how do you reverse the T cell exhaustion that we see in these patients to get these immune cells to actually kill the tumor? One way, based on Sabina's lab's work, is to look at the expression of secondary, sort of negative checkpoints, like TIM3 and LAG3. What her group has shown in retrospective studies with nivolumab is if the tumor's immune cells express PD-1 but don't express TIM3 and LAG3, they're more likely to benefit from PD-1. However, if they're expressing all these negative checkpoints, they're considered terminally exhausted, like I feel right about now, and can't be reversed with just PD-1 alone. So how might you overcome that? Well, her translational research provides a biologic rationale for looking at LAG3-based combinations in kidney cancer. You saw some of that in Jose's talk just a minute ago. This is an approach that's shown proven benefit in melanoma, and several randomized trials in the cooperative group are underway or planned. Another approach, what we've learned from these immune cells in the tumor, is a lot of them are T regulatory cells, which are dampening the immune response to the tumor. How can you turn some cold tumors hot? Well, one approach that's worked in MSS colorectal cancer is looking at Treg depletion through novel CTLA-4 antibodies like botensilimab. So the combination of botensilimab with PD-1 is now being compared in HCRN to Nivo-IPI. Mike Serzin and Mike Atkins are leading this trial. This trial it helped come to fruition based on the work that was done on human samples from prior treated patients, which I think is the way to go in the future. But it's not about giving everyone immune therapy. We have to rationally apply these drugs. We've obviously not made a tremendous amount of progress on predictive biomarkers. What's the way forward? Well, as Renee Salibi said last year, and Kim Rathmel said this year at ASCO, I think as they said, given the complexity of kidney cancer, it's likely we're going to need to integrate numerous biomarkers to have a truly predictive tool for our patients. There were some good examples at ASCO of moving in that direction, one of which came from the Emotion 010 study, and Monty presented this data at ASCO. I think this trial is really important. I know many people just look at it as a negative study, but we learned a lot from this study that's going to help us going forward. It's the first exploration of this type in the adjuvant setting where they looked at paired biopsies, both before and after treatment, which addressed critical questions for not just kidney cancer, but the entire immune checkpoint world about what drives PD-1 resistance and which patients should get adjuvant treatment, because we're clearly over-treating a large number of our patients at the moment. And so they're giving us clues on what targets might be relevant in the PD-1 failure patients, which unfortunately most of our patients are. And they also gave us some interesting insights about the value of serum biomarkers like KIM-1 compared to tissue biomarkers, suggesting that KIM-1 might have a role. Vincent, I'm sure, is going to talk about this more in predicting who should get adjuvant therapy. But the other way to make progress is to allow patients who've just had adjuvant therapy onto our advanced kidney cancer trials in the front line. This is an example of one of those. Toni mentioned this at ASCO, and I'm sure it's going to be talked about later this afternoon. This is the PEAK-1 trial, and you can get on this study, is my understanding, if you've just failed PD-1 in the adjuvant setting. This is particularly sampling the tumors of those patients is going to be particularly important for us to understand how to treat these patients. The other thing that I alluded to is blood-based biomarkers, not just KIM-1, as Vincent is going to describe, probably, but also DNA-based methods like ctDNA and epigenomics are showing some progress. This might give us a sense of how patients are doing earlier on treatment. So, for example, KIM-1 high levels have been associated with lack of response in at least 2 data sets. But also KIM-1 decreases may be associated with outcomes. So you could imagine a world where our blood tests might tell you whether you could stop treatment or, just as importantly, escalate treatment, which I'll come back to in a second. One of the weaknesses of all of these data sets is I don't think any of us really expected the long-term 5-year, 10-year outcomes that we saw with these studies, which are exciting, but we're not great at measuring long-term outcomes. We're also not great at measuring both the pluses and the minuses of these treatments, because not just durable benefit can go on for a while, but so can the toxicity. So Meredith Regan and colleagues have been looking at a partition survival analysis where they measure the durable positive, like remissions, but also durable toxicity and treatment-free survival, summarizing the outcome in all patients and developing a tool that we can use to talk to patients before we start treatment. But even a more important question is, how can we generate more of this treatment-free survival, leading to remissions, leading to cures? Well, there's several approaches to that. You could do more observation, as our folks from Cleveland Clinic have suggested. You could even stop drugs early, which is a novel concept, which the pedigree investigators are looking at. But I think the last thing I want to say is the other thing we could do is what Dr. Einhorn suggested over 40 years ago for testicular cancer, and what we now do as a standard for testicular cancer, but also in lymphoma, is in patients who are getting an inadequate response, we could push in the right patient to more aggressive therapies. I think if we don't take that approach, all these exciting things we're hearing about at this meeting, like CAR-T and TIL, and I'm sure Chuck is going to talk about T-cell engagers, if we don't take that approach, all of these exciting approaches are going to be much harder to develop, and patients are going to potentially miss out on the opportunity for remissions and cures. But if we do this, we use integrated models, we can more appropriately assign patients to first-line treatment. So when we're here 5 years from now, second-line treatment, that Bob is about to talk about, won't be as necessary, because our patients are going to be living in remission. I know I went over, I apologize. Here are my acknowledgments. Thank you all for those who went on the trials and for the slide help that I got and the funding, which is critically important. And the last thing I want to say is the advocates, like the folks at KidneyCAN, who push for funding translational research. We need to thank them and encourage their efforts. Thank you for your attention.
Bob, the floor is yours. I can't think of anyone the past 20, 30, 40, I don't know, years than Bob Motzer out of Sloan Kettering, who changed how we treat kidney cancer.
Okay.
Bob?
Thanks very much. So I was thinking as David was going through his talk that it's actually a very positive thing that our talks are going beyond the time allotted to us. So I can remember, back in the day, we could cover the entire field of kidney cancer in 5 slides. Our talks were very short, and my mentor, who was Alan Yagoda, would run through the entire treatment with five slides of negative studies. So I think it indicates very active field, lots of progress, and it's actually a very, very positive thing. So I'm going to run through the subsequent treatment for advanced disease. Normally what I've done is kind of given you a snapshot for what's new over the last year since our last meeting in this field. And so for subsequent therapy, we're just going to cover these different areas. Usually what I do is review the ESMO, GU ASCO, and ASCO talks to look at, to highlight for the subsequent therapy. This is the NCCN guidelines. We're not going to spend a lot of time with this. You can look at this, but basically it falls into 2 categories: patients who have started on TKI as their initial therapy, or patients who have started on IO combinations. And so the first part of that, the top, can really be, I think, could be crossed off. I mean, that's no longer a relevant paradigm. The paradigm really is what to do for patients who have had IO combinations in first-line therapy. And anytime there's a change in paradigm early on, we're left with a dearth of information in terms of what to do for subsequent therapy. And so that's where we are now with this change in paradigm that happened around 2017 with the Ipi-Nivo phase 3 trial and then the TKI-IO combinations. And so you can look on the NCCN, and I think there's going to be an update out any day now for the new year, but there's really a lack of phase 3 data suggesting a benefit for one treatment over another. So, one of the questions that's come up is in terms of whether there's a benefit to continue IO therapy for people who have progressed on IO combinations first line. The CONTACT trial we reviewed last year, that was the large phase 3 trial that Toni and Tom led for cabozantinib versus cabo plus atezo, showing no benefit in PFS, or as you can see on this slide, no benefit in OS for that combination. The more recent one was Tonivo study, which is shown on the right. This was presented at ESMO, again by Toni. And so this showed no benefit of the combination of Tivo plus Nivo over monotherapy with Tivo. Since that time, there's been some subset analysis looking at different groups. And so this slide here summarizes the Tivo as the most, in ICI as the most recent therapy with outcome for the trial, or whether the patients received a TKI as the therapy before going on the study. Shows really kind of a difference, and so I think it highlights the fact that there is really heterogeneity in the trials, and different subgroups do differently based on what their prior therapy is. My own take on this is Tivo monotherapy in patients who have had ICI as their most recent therapy, or in another slide, a second-line therapy, really do pretty well. Now, one of the real pluses of Tivo as well, as was shown here at ESMO, and that is the side effect profile. For those of you who have used tivozanib, with the exception of the hypertension, which is manageable, it really has very little in the way of off-target toxicities. And that's why I do think if we're going to continue to study TKIs in the adjuvant study, to Brad McGregor's credit, I think Tivo is probably the best at TKI at this time to try in that space, in the adjuvant space. The other big findings that have been presented was this update of the LightSpark 005 trial, which was the groundbreaking study that compared the HIF inhibitor to everolimus. And so this study showed that there wasn't any additional survival benefit for belzutifan in this setting, but there were certainly benefits in progression-free survival and durability of response with fairly good toxicity and certainly different toxicity profile than our TKIs. And so this was presented by Brian Rinne at the ESMO meeting. Now, in terms of where things are going with HIF inhibitors and belzutifan, this was a study, the umbrella study that's sponsored by Merck that many of us have participated in. And this was presented, this was Laurence's abstract that it was from GU ASCO, I think, that was presented by Katie Beckerman. And it shows the combination of belzutifan in subsequent therapy. There's multiple arms here. And so the different arms were belzutifan plus lenvatinib, or belzutifan plus pembro, or a triplet. And so what this showed is that there seems to be good activity for combining belzutifan plus lenvatinib with a reasonable toxicity profile that is really doesn't show any kind of particularly overlapping toxicities. And so this highlights, this is the toxicity profile that was shown, and I borrowed some of these slides from Tian Zhang's wonderful overview and discussion of this. So this is an area in subsequent therapy, I think that's kind of the hottest area right now, and that is how to combine belzutifan in our case in subsequent therapy, also as well in first line and adjuvant. And this particular study suggests that there's a higher level of activity for combining it with lenvatinib, and that could be a reasonable combination to follow. Now, the other area I think that was important that you should be aware of, and I know that you're going to be hearing about this more later from Toni, was the Arcus HIF inhibitor. And so this is one of the studies that is, again, one of the early studies with that. I know you're going to hear about more of this later, but it showed this compound in combination and in single agent. The single agent data is shown here, summarized from, I think this was GU ASCO, right? And it shows clear-cut activity for this compound in heavily pretreated patients. So I think, there's been some debate back and forth about relative aspects of this, but from my standpoint, it really is confirmatory towards the fact that molecules with this mechanism of action show activity in RCC and may play a very important role. This was the study that he reported at June ASCO for this novel HIF inhibitor in combination with cabozantinib. And it again suggests that there's a higher level of activity when you're combining HIF inhibitors with TKI. And so this is really an area I think that we have to keep a close eye on. This was a summary slide for all the HIF inhibitor trials in refractory RCC. And so again, my take on this is that they're confirmatory. When we see multiple studies showing activity with different agents of the same class, I think that's a good thing because it shows we're on the right path. And in addition, of the studies that are combining a HIF inhibitor with TKI, they're all showing higher response rates. They seem to have higher response rates compared to the HIF inhibitor as a single agent. Whether they're going to have higher response rates and success rate compared to the TKI is really the real question for us right now. And so that's what's being pursued in these large phase 3 trials that in my mind are ones, again, that we should really keep an eye on because they very well may change the standard of care. So the first trial is the LightSpark 011, which is belzutifan plus lenvatinib compared to cabozantinib, and that has completed accrual. We're waiting for a readout of that. And then the other one is the PEAK-1 trial, which is casdatifan plus cabozantinib compared to cabozantinib. I'm not sure whether that has actually started enrolling yet. I guess we'll hear about that later, but it certainly has got the go-ahead, and we'll look forward to that one as well in terms of enrolling patients in outcome. Now, more to come here, and we heard earlier from the Exelixis folks about the zanzalintinib, which is an exciting new TKI. Hopefully, we'll have the same or better efficacy than cabozantinib, but better tolerated. And so these were two press releases from both Exelixis and Merck indicating that there's a marriage going on between belzutifan and zanzalintinib. So we hope this will be a happy marriage and will play out and again show more improvement in terms of efficacy for combination therapy, and we're kind of eagerly waiting to find out a little bit more about what these studies entail. At the meeting, this was an abstract on CAR T from Dr. Choueiri from MD Anderson and our own Ritesh Katisha from Memorial Hospital, showing really promise for this CAR T program in RCC with a good level of activity and relative safety. So I think the cellular therapies and CAR T is something, again, that really shows promise for moving the field forward. Lastly, the new frontier, as you're hearing about, is what to do for patients who have relapsed or progressed through adjuvant therapy. That's an area that I'm particularly interested in, well, since I see a very large population of patients receiving adjuvant therapy. And so on the right is a diagram that was set up for, I think, the ASCO post from a couple of our colleagues suggesting a paradigm for how to treat patients who relapse from pembro adjuvant therapy. Now, I think that this is a great effort, but I think it is a little simplistic and somewhat arbitrary. These are the subsequent therapies for patients that were treated in KEYNOTE-5 in the adjuvant pembro study. So the ones that you can see are obviously for pembro on the left. And so I think that systemic therapy is really important here to define, but I think that there are other avenues for managing these patients as well, some of what you heard yesterday, and they include metastatectomy for patients relapsing with small volume disease, or ablative techniques, since in my own practice I found that many of these patients really, since they're being monitored very closely, are relapsing really with very small asymptomatic pulmonary disease. So I think those other avenues in addition to systemic therapies are ones that we should pursue for that population. And in terms of the management strategies, this is a kind of a roadmap that my colleague at Memorial, Dr. Voss, and I put together and published that does kind of break down the idea of how to manage these patients from time zone, from time for relapse for pembro. But I think there's also a lot of other factors that need to be included, and they include, what was their tolerance to pembro? How many doses did they receive? And when was the last dose received? But also, what was the timing to the relapse? What are the metastatic sites and the tumor burden? Because I do think many of these people can be managed with localized therapy, at least for a time. What are their symptoms? And when they relapsed, and those are the patients who tend to need more systemic therapy. And some of the other factors, like, are they still have lingering toxicities to the pembro? So I think that those are all different things that are going to go into this complex situation in terms of how to manage those patients. And so lastly, I'll just kind of lead you with, I think that the important part of this meeting is discussion. Really a wonderful group of bright people here with new ideas. And so, I think some of the questions that come up in this area of subsequent therapy is, how do the HIF inhibitors best fit into the treatment paradigm? What line of therapy? Will it be adjuvant therapy? Will it be in first-line therapy? Or will it be in combination with TKIs and subsequent therapy like the studies I've shown? We mentioned about how to manage people after adjuvant monotherapy with pembrolizumab. But I think, two of the bigger questions really are, we have so many options now. You know, how for our new drugs, I mean, in this crowded therapeutic landscape, I mean, how do we really kind of develop those drugs? It's become much, much more difficult. I tell people that when we originally designed the 1032 trial, which was sunitinib compared to interferon, which I proposed to Pfizer, didn't take a genius to figure that one out, right? Very simple thing to figure that out, but it's become much more difficult in terms of how to design trials that are going to change the standard of care because of the landscape so crowded. And also, what do we think is the next therapeutic breakthrough in RCC? I mean, are we at a plateau now? Is it, will CAR T therapy, do we think that that's going to show the most promise? Or what are kind of ideas from the groups about that? And so I'll leave you with that. That's my last slide, and thank everyone for allowing me to talk again here, and for you all for listening.
Thank you, Bob. Thank you, Bob. My pleasure to present Naomi Haas, my good friend from Penn. If you don't know that, but Dr. Haas was the person that launched the field of modern adjuvant therapy with her large Assure trial of TKI at the same time, and was involved in many adjuvant immunotherapy trials, including the last update of Keynote 564 at ASCO. Naomi?
So thank you, Toni, and thank you for the organizers for inviting me. My talk is more of a advertisement, I think, of things to come. But I think that you know, what we've learned from adjuvant therapy and what has been emphasized this year was the long-term follow-up of Keynote 564, which I don't have a slide for, but which we showed that all the patients had met the 5-year follow-up, and that the curves for both disease-free survival and overall survival remain separated and quite robust. But there are a number of knowledge gaps that we're all aware of, and that is what I've tried to emphasize in these next upcoming slides. For example, the duration of therapy, you know, when we designed the Assure trial, we just somewhat arbitrarily picked a year, and most of the adjuvant trials have given a year of therapy. You saw some variability with the 4 adjuvant and perioperative trials that were conducted and reported out several years ago, in which the BMS trial was a 6-month period of time, and the perioperative Prosper trial had treatment before and 9 months of treatment afterwards, but we don't really know what the duration of therapy should be. We also don't know all of the patients who don't need adjuvant therapy, and we also don't know in that group of patients who should get more intensive therapy. We are seeing promising markers such as KIM-1, and Vince will talk more about that, but we still have a lot to learn. And then additionally, you know, should we be targeting additional mechanisms to improve the outcomes? And does neoadjuvant therapy work in RCC? People weren't happy with the results of Prosper, especially when there were all these promising neoadjuvant trials in melanoma and non-small cell lung cancer and other solid tumors. And so there's been a lot of discussion about should we be looking more intensively in that space. So I'm going to just mention the recently completed trials that have pending results, the Rampart, LightSpark, InterPath, and I do try to transparently mention things that I see on clinicaltrials.gov. So that's a Chinese trial at the bottom, which is a VEGF TKI with an immune checkpoint inhibitor that is also shown to be open. The Rampart trial is soon to report, I believe. It's 1,750 patients. And this trial, which was revamped a little bit after the results of the other adjuvant trials, is looking at a PD-L1 inhibitor in combination with the CTLA-4. So one arm is active surveillance, another one is single agent durvalumab, and the third is the combination of that with tremelimumab. And so we are looking forward to those results. That one also did include some patients who'd had metastatectomy. LightSpark, as you know, is looking at whether you add a HIF inhibitor to pembrolizumab and comparing this to pembrolizumab alone with the primary endpoint of disease-free survival and secondary of overall survival, and we anxiously await those results as well. The InterPath trial just recently finished accrual, and this is looking at the very exciting mRNA vaccine in combination with pembrolizumab and versus pembro alone, and I myself am really hoping that this shows a benefit because I think that there's a lot of excitement about using this in the oligometastatic state, and the patients are certainly, for whatever reason, very excited about vaccine trials in this setting. As far as ongoing adjuvant trials, Brad McGregor gave a really good presentation for the STRIKE trial. Again, there's a Chinese trial ongoing looking at a PD-1 inhibitor that had shown in metastatic setting to improve overall survival. And I did want to highlight a couple of things in development. There's also a Chinese trial that is looking at a VEGF and PD-1 inhibitor in non-clear cell. So first STRIKE, you saw this slide from Brad yesterday, but the idea with this is it's a slightly over 1,000 patient trial looking to see whether intensive treatment with tivozanib in combination with pembrolizumab will improve both disease-free survival and overall survival. I think what's really exciting about this is it's an all-hands-on-deck effort to really do a great job of collecting correlative samples in a lot of things that the group does really well, including minimal residual disease, DNA methylation, KIM1, collecting digital pathology and radiomics, and looking at a number of other things such as cytokine analysis. So this trial looks as if a number of patients have already accrued, so that's very promising, and we look forward to the success of this trial. I did want to highlight a trial that is being done at City of Hope that Wesley Yip and Monty Paul were very nice to share their slides. This is based on the use of CBM 588, which showed impact of microbiome modulation in the metastatic setting, and so you can see the curves below from both the Ipi-Nivo and the with CBM 588 and the Cabo-Nivo with CBM 588, which showed an improvement in PFS in the advanced disease setting. And so they also observed in both of those trials that there was an increase in IL-12 with CBM 588. As you can see, to the left is the Ipi-Nivo and to the right is the Cabo-Nivo. And so what they've done in this schema is this is a relatively small trial. It's 56 patients. They expect to screen about 62 patients, and they will be randomly assigned to get pembrolizumab alone or pembrolizumab with CBM 588 with a robust sampling of both blood and stool samples, both before and at different time points. And the primary endpoint is basically going to be the change in IL-12 levels from baseline to week 12, but they will be capturing data on recurrence-free survival and overall survival. So I think that, Monty and Wesley, if you need other sites, we'd be really happy to be a site if it turns out that way. And then I think Asim will be showing a more detailed slide, but this is ECOG 8252, which is a trial that is going back for final review of the steering committee next month. And this is incorporating treatment of non-clear cell RCC in the adjuvant setting. It has been changed to a 1-to-1 randomization with pembrolizumab versus active surveillance. We will be It is powered to papillary, and we will be collecting data in a very separate fashion of all of the non-clear cell RCC types. So we will learn something. I know there's been a lot of discussion about whether these should be individual trials, but I think it becomes very costly when you try to do many little niche trials as well. And I did want to highlight some other ongoing correlative studies just to say that there are a lot of different ways that you can answer questions, and these are some other ones on the website, but I think particularly interesting are even things such as an observational study of the effectiveness of funded drugs. I mean, I think we need to look at the cost and the risk-benefit with toxicity. MRD GATE is a trial that has suffered from the approval of adjuvant pembrolizumab. This was a well-thoughtful study in which patients who were MRD positive or negative could be randomized to get either pembrolizumab or observation. It started before the results of Keynote 564. It's open in, I think it's University of Alabama, and I know Dr. Basu has recently left the institution, but my understanding is they're still collecting data retrospectively in patients that are either opting for observation or opting for adjuvant therapy, so we should learn something with that. And then lastly, I wanted to just highlight some of the neoadjuvant trials that are ongoing. This is a European one looking at Nivo by itself, or Ipi-Nivo, or LAG-3 with nivolumab, with the primary endpoint being pathologic response. And I know Axel Bexel and Grant Stewart have been talking, we'll probably be talking more about this space as well. And this is the BLAZE trial. This is a small trial, 56 patients, 18 per arm, that is looking at belzutifan, so HIF-1 by itself, pembro by itself, or the combination, and then in patients going on to resection of their tumor. The primary endpoint is a composite endpoint of objective response rate and also pathologic response. The PI is Udit Singhal at the University of Michigan, and this trial is under regulatory review and soon to open in the KCRC. This is NeoShift, which is Toni's baby, and this is a much larger trial of 774 patients in which there are 4 arms using each of those 3 combinations that I just mentioned, but also importantly having an experimental arm as standard of care in which patients wouldn't get treatment and then go on to radical nephrectomy, with patients who are eligible for Keynote 564 after, based on their pathologic tissue, going on to get adjuvant pembro. And then finally, I think the take-home messages are that we really want everybody to continue to support local and national adjuvant studies. So I'll stop there. Thank you.
Pleasure also to present Dr. Asim Bilen, a rising star who leads the GU group at Emory and who has a special interest in non-clear cell kidney cancer.
Perfect.
Asim.
Thank you so much, Toni, for the kind invitation. It's really glad to be part of this esteemed group. I think this meeting is very, very special. But before I start my talk, I really want to give a special shout out for 2 amazing, wonderful ladies. One of them is Deb. I see you over there. And then I don't see Meryl. Is also on the back. Yeah, we are running our kidney cancer marathon together. And soon it's going to be 10 years. And they really push me hard what I do in clinic. And they put a lot of effort in this meeting. Please give them a round of applause. Yeah, Deb, sorry. If you invite me, I will keep you a shout out to you. I'm going to start my talk, which is really strategies for rare subtypes of kidney cancer. We have a lot of great talks earlier yesterday, but it's going to be a quick overview. and then and looking forward to our discussion. Here's my disclosures. As we know, kidney cancer is a diverse subgroup. We have the common suspect, which is clear cell kidney cancer, but we have all these other small subtypes that we see in our clinic, especially being an academic center. We got a lot of second opinion and referral. And there's some changes in the subgrouping. We are not calling type 1, type 2 papillary. We just call papillary. And then we have all these other small groups, like a collecting dog, chromophobe, and others. And we clearly need more therapy for this patient population. Also, we use a lot of genomics, we do next-gen sequencing and germline testing, and I think this is very, very important for rare variant kidney cancer, because we are not only diagnose them via pathology, we are also diagnose them via molecular alteration, such as FH-driven cancer, SMARCB1, altered kidney cancer, translocation, and others. And this also highlight the importance of molecular testing in this patient population. How we treat localized non-clear cell kidney cancer, I think currently surgery is way to go, and there is really no prospective data for adjuvant therapy, and I think this is a high unmet need for our patient, because we all try to extrapolate Keynote 564, but we don't have any data for this group. As Naomi highlighted, we have a cooperative group study. I think this is really, really an important study, in the cooperative group mechanism. Hopefully, we're going to activate this trial soon, which is EA8252. It's a pretty straightforward trial after nephrectomy, a patient randomized either pembro versus active surveillance. And the current design is randomized phase 3, one-to-one randomization, and then we are looking around 360 patients. And the primary endpoint for that study is 2-year DFS, and then overall survival and others are the secondary endpoints. We really need to work together for this trial. I think this is all hands in deck, medical oncology, urology. Once the study is hopefully activated, we really, really appreciated your support. And then if anyone interested in part of the correlatives and others, please let us know. What about metastatic non-clear cell RCC? I think the current reality is, although we have all these different subtypes, we almost exclusively tested clear cell RCC drugs in non-clear cell RCC. I think we are successful. I think things are heading on the right direction, but definitely there is a room for improvement and ultimately cure for this patient population. I think Dr. Tanir and others really set the stage for this disease, like ESPN and Aspen trial, show the activity of sunitinib in this patient population. And for many, many decades, sunitinib is our standard of care drug for non-clear cell RCC. Even a lot of part in the world still using sunitinib, since the other drugs are not available. But after then, we switched the gears and then moved cabozantinib. Dr. Paul led the PubMed trial, which I think is a very, very important randomized phase 2 trial. A patient with papillary RCC enrolled in this and randomized sunitinib, cabozantinib, and then 2 MET arm. And ultimately, the MET arm closed early due to futility. And the study basically compares sunitinib and cabozantinib. And that showed the activity of cabozantinib in this patient population, which is a very encouraging response rate, more than 20%, positive PFS, although the study is not powered for overall survival, there is no difference in overall survival. But this drug is really used first line in patients with non-clear cell, especially papillary RCC today. But things very quickly go to combination. I think this is an important trial led by MSK group, cabozantinib and nivo in non-clear cell RCC. As you see in the waterfall plot, is a very, very encouraging activity. Almost every patient have tumor reduction. Response rate is close to 50. Although chromophobe patients have some reduction, but because there is no response, they close that arm. And then, we only have 6 patients with chromophobe. If you look at the PFS and OS, it's also very encouraging, 12 months PFS, 28 months overall survival. And because of that trial, we also use nivo-cabo in our clinical practice. And another important trial is Keynote B61. I think we have some long-term follow-up later today. combination of pembro plus lenvatinib. Dr. Albijans led this study, which I think is the largest non-clear cell trial to date, close to 160 patients enrolled. It's an international phase 2 trial, single arm, all different histology enroll. And as you see, the response rate is quite encouraging. Not only papillary, we see response across the board, unclassified, translocation, and interestingly, chromophobe also we see response with this combination. Median PFS is 18 months, 1 year overall survival 82%. And based on this trial, this combination also become available for our patient with non-clear cell histology. I think for a long time, we all strongly believe VEGF should be part of the cocktail for patients with non-clear cell RCC. I think this sunny forecast give us a pause and really give us the activity of Ipi-Nivo in this subset. I think overall, to be honest, I think the activity is much better than I expected. The median OS is close to 42 months, the 12-month overall survival is significantly better in Nivo-Ipi versus sunitinib. And there didn't see any big difference between papillary and non-papillary, and there is no differences in a PFS. I think overall this is an important trial, although it's a relatively small trial, but I think this also highlight maybe there is a role for dual checkpoint inhibition in patients with non-clear cell RCC. I think this is to me, I think it's a very important trial. Finally, we have a New England Journal of Medicine in non-clear cell RCC. This was published very recently, a couple of weeks ago. Kudos to NCI group, bringing this combination in patients with hereditary, and sporadic papillary kidney cancer. As you see in this paper, there is a group which is HLRCC, and the response rate is quite remarkable, close to 75%. No PD, primary PD, which is also amazing because we know this group is very, very aggressive. But also the activity seen in the sporadic population, a close to 40% response rate. And if you look at the median PFS, 21 months in HLRCC, almost 9 months in a sporadic patient. I think this highlights the activity of this combination, and we also start using this, and it's part of our guideline. What about other combination? Lenvima everolimus, I think, is another thing we use, maybe not first line, but definitely second line and beyond. This is a single arm trial, show the activity of this combo, close to 30% response rate. I think another highlight of this trial in chromophobe, because this is a population we really struggle in the clinic, but somehow Lenvima-based combination have an activity in chromophobe, and this is another combo we are using today. There is also other combination Cabo-Atizo, which is a PD-L1 based combination, bevacizumab-Atizo. Again, still active combo. We are not using much in current practice, but show the highlight of IO-TKI in this patient population. What about MET? I know Toni and Tom did a lot of work with savolitinib. There is a single-arm phase 2 trial combining savolitinib plus durva. Response rate, again, is very encouraging, 30% unselected patient, and MET-driven is close to 55%. The median PFS, 4.9 months, a MET-driven patient, PFS 12 months, OS close to 30 months. This is also highlighting another very active combo in this group of patients, which is MET plus PD-L1, and then I think things are heading on the right direction. What's pending? A PubMed2, I think very, very important trial we all need to support. Although we are using a lot of combo, but I think that question still need to be answered. This is a randomized phase 2 trial, Cabo versus Cabo-Atizo. It's still enrolling. I think we all need to support, and hopefully this study reach the finish line. Another important trial is Stellar 304, combining Zanza plus Nivo versus sunitinib. That's also completed and soon to be reported. And the MET combo is in the phase 3 setting, a savolitinib plus durva, Sameta trial, testing that combination and currently enrolling globally. And the Bev, erlotinib combination, there is a follow-up trial at NCI, which is open multiple institutions around the country, and they are adding Atizo in this cocktail. And again, sporadic papillary is included, HLRCC included, and they also have a pediatric population, and that study is also enrolling quite well, and hopefully we able to move the needle forward like in this rare subtype of patient. I think lastly, there is still a lot of questions we need to answer. Again, adjuvant therapy in non-clear cell need to be answered. Hopefully we can do this together. I think the ideal frontline therapy is still debatable, like what combo we need to use. Should we just go IO-VEGF, which one, or IO-IO? I think we need to do more studies and maybe more real-world studies to get some data to practice. And second line and beyond is wide open. I think we need more targets and more drugs in this group of patients. We are combining all these subsets, but I think ultimately, like the rare histology, we don't have much data. Maybe another avenue of real-world studies for this group of patients. And ultimately, I think we are lacking biomarker, like who is benefiting, who is not, what we should do, what's the mechanism of resistance. I think we still need to collect as much as sample from our patient to come up a good biomarker in this rare subgroup of patient. But overall, things are moving on the right direction. We are talking 50%, 60%, 70% response rate. I think this is quite encouraging. But clinical trials are way to go. Like we really need to work together, make our studies more easy, real world, pragmatic, and hopefully get as much as data as possible. Thank you.
And so what's new on the horizon? Dr. Tai Ho from MUSC is going to tell us what are the new targets and drugs in RCC, hopefully.
All right. Thank you for the meeting organizer for giving me the opportunity to speak today about novel therapies outside immunotherapy in renal cell carcinoma. These are my disclosures. So kidney cancer doesn't follow a traditional cancer playbook. It doesn't respond to traditional cytotoxic therapy, and it has intratumoral heterogeneity. So at any given time, there's multiple clones present in the same population. Given the low incidence of traditional driver mutations, such as KRAS and TP53, there's a high incidence of chromatin remodeling mutations. So this actually gives it an advantage where the genome is actually poised to already respond to any kind of external stimuli. So there's a lot of metabolic reprogramming that occurs in both the tumor and the tumor microenvironment. As an example of a terrifying mechanism of action, you can go to Dr. Brugueros' presentation on mTOR resistance, and he showed that basically rapalog resistance is not conferred by the tumor itself, but a paracrine effect on the tumor microenvironment. So this makes it very different from a lot of our traditional tumors. So in terms of our different molecules that we have available, we have small molecules that target tyrosine kinase inhibitors, HIF2 inhibitors, mTOR inhibitors, and then we also have monoclonal antibodies. Small molecules have the advantages in that they can target the tumor microenvironment, they can target things inside the cell as well as the nucleus. Whereas monoclonal antibodies, because of the higher molecular weight, they're essentially relegated to the tumor microenvironment, or they have to undergo active endocytosis to get into the cell for a direct tumor effect. So as I sat through a lot of the presentations, I had to take an educated guess on what Dr. McDermott and Dr. Motzer would have to present, so this actually makes it a little bit easier for me. So the way I set up all my slides is basically on the right side is a snapshot of what's going through my mind as they present me the data in real time. So the reason why I put up the progression-free survivals, response rates, and overall survivals on the right is just to give me a sense of what the ranges of responses I get with therapies I have available to, and then how new therapies, does it fall within the range of what I have available now. So this is the combination of a HIF2 inhibitor with cabozantinib. This is from the LightSpark 003. This is presented by Toni and published in Lancet Oncology 2025. Response rate was 70%, progression-free survival of 30 months. Zanzalintinib is essentially a novel tyrosine kinase inhibitor, has a shorter half-life than cabozantinib, so this may improve upon the safety profile of cabozantinib. It also has a slightly different TKI profile, and that targets some of the TAM kinases, and this may be able to overcome some of the resistance to VEGFR inhibition. This is presented by Dr. Choueiri in 2025, where the combination of zanzalintinib plus PD-1 therapy had a response rate of 63%, combination with PD-1 with Opdualag or LAG-3 was 40%. So thinking about second-line therapies, one of the first clues that combination therapies may add on to single-agent therapy was the trial of lenvatinib everolimus versus lenvatinib in a phase 2 setting. So here you can see that the combination study gave us some clues that we could add 2 drugs or 2 tyrosine kinase inhibitors together that could potentially be tolerated by patients. So this is the first clue. And then the other things I also pulled from the other presentations is basically in the post-IO setting, what was the performance of single-agent TKIs such as cabozantinib or tivozanib. So it kind of gives us a sense of ranges of activity of what to expect in second-line therapy or later for patients previously treated with immunotherapy. So this is the combination of belzutifan plus cabozantinib in a second-line therapy, LIGHTSPARK-003 cohort 2. This is published in Lancet 2023, where the response rate was 30%, progression-free survival of 14 months. So this is another trial where they looked at belzutifan plus lenvatinib. So this trial kind of gives us the question, is your TKI partner important? Does it influence the overall activity of the combination partner? So this is presented in 2025 by Dr. Katie Beckerman, where the response rate was 47%, progression-free survival of 12.5 months. So Toni presented this as the monotherapy. This is the ARC-20 monotherapy arm. There was 2 doses. There's a 50 milligram dose and the 100 milligram dose. And here's the waterfall plot on the left. And essentially, you had a response rate of 25% at 50 milligrams, and then response rate of 33% for 100, and 100 milligrams is the dose going forward for combinations. I'll also present later as well with casdatifan 100, cabozantinib 60, where the response rate was 46%. So one thing to note on these waterfall plots for a lot of these HIF-2 combination therapies is there's a population of patients who have a complete response. So despite failing prior immune therapy, there's a subpopulation of patients that seem to have a very good response to combination HIF-2 inhibitors as well as TKIs, and this is seen in both the casdatifan and the belzutifan data. So this is presented by Dr. Eric Yonash. This is NKT2152. The response rate here was 20%, progression-free survival of 7.4 months. What I thought was particularly interesting in this particular study is that there's a population of patients who have not been received mTOR inhibitors, and that response rate was 35.6, and the progression-free survival was 12.7 months. So this population of patients who are mTOR naive with higher responses, it may reflect a patient population who have non-overlapping mechanisms of action and resistance, or less heavily pretreated populations. So thinking outside of HIF-2 inhibitors, we have now radioligand therapies. So sort of in a nutshell, we have 2 flavors of radioligand therapies. You have alpha and beta emitters. For physicians and healthcare providers who are treating prostate cancer, you have experience of using alpha emitters such as radium-223 or Xofigo, as well as beta emitters using therapies like Pluvicto. So essentially, just a quick compare and contrast between alpha and beta emitters. For alpha emitters, you have actinium, radium, lead. For beta emitters, you have lutetium, yttrium, samarium, and iodine. So within the ranges of activity, when you think about the distance for an alpha emitter versus a beta emitter, the alpha emitter is fairly short compared to that of a beta emitter, and there's a very high level of linear energy transfer for an alpha emitter compared to a beta emitter. So sometimes this actually causes different types of DNA breaks, and this may actually influence some of the mechanisms where it may be able to stimulate the immune system. So with DNA damage on alpha emitters, you get double-stranded breaks, whereas with beta emitters, you may get single-stranded breaks. So some of the therapies now include monoclonal antibodies, as well as peptide-based therapies. The advantage of a monoclonal antibody targeting CA9 is, number one, this is cleared by the reticular endothelial system and the liver system, so there's less off-target activity potentially on the kidney, where peptides often are concentrated in the proximal convoluted tubule. The other advantage is that you can swap out some of the alpha versus beta emitters and see if this changes the activity. On the other hand, we have access to PSMA-directed therapies. Dr. McKay's group showed that the mRNA for a PSMA is expressed on the surface or is expressed in renal cell carcinoma, and we know that some of the neovasculature also expresses PSMA. So there are 2 ways to get radioligand therapies. So thinking about the different mechanisms of resistance post-HIF-2, you can have imagine two mechanisms of action. One is intrinsic resistance. So within LIGHTSPARK-005, about 34% of patients had progressive disease as their best response. So some patients seem to be, for whatever reason, intrinsically resistant. The response rates of belzutifan was lower than what we expected from the prevalence of VHL mutations. And what's interesting is in LIGHTSPARK-004, this is a population of patients who had a germline hereditary associated renal cell carcinoma, and the median time of response was 11 months. So there may be a delay in response for single agent therapies. The other mechanism of resistance is what we call acquired resistance. So we see this with a lot of small molecule inhibitors where there's a gatekeeper mutation, and this basically blocks binding of the HIF2 inhibitor, and this leads to resistant clones. So post-HIF2 inhibitor therapy, we could think about two different modes of targeting these therapies. One is to use cell therapies. These kind of overwhelm the immune system and overcome prior immune resistance. You might be able to rotate between different tyrosine kinase inhibitors. You can switch to another mechanism of action like the mTOR inhibitors. We also saw in Cancer Discovery, this was actually published July 2025, where Bill Kalin's lab showed that cyclin D1 is a primary mediator of resistance to belzutifan, intrinsic resistance. So for some of these patients, this is the rationale or preclinical rationale for combinations with some of these CDK4/6 inhibitors. Other novel mechanisms of action include the stress pathways such as GCN2 and the farnesyltransferase inhibitors, and then the radioligand therapies. For that population who have a G323E resistance mutation, you may be able to overcome this with molecular glues. So these are sort of in the same class as IMiDs like pomalidomide, lenalidomide, where they actually bind outside the binding site mutation. They could overcome some of these resistance alterations. And the other one would be using siRNA-based approaches. So just to summarize my thoughts, these HIF2 inhibitors represent a mechanism designed for kidney cancer. These weren't drugs that had failed other diseases, and then someone decided, well, let's just try it in kidney cancer and see if it works. These have non-overlapping toxicities with TKIs, and they're active post-IO therapy. The other advantage is some of them have CNS penetration, so I think this is an area of need where patients with brain metastases are often excluded from a lot of our studies. Some of the limitations of single agents may include delayed responses and higher rates of progressive disease. As Dr. Powell mentioned in his studies, there's a lot of limitations of over-interpreting these phase 1-2 studies, and they include differences in patient populations, shorter follow-ups, and attenuation of responses in a larger phase 3. However, these combinations of HIF2 inhibitors and TKIs may serve as a foundation for an IO-free option for patients who are intolerant or ineligible for immune therapy. And with multiple TKIs already approved in second-line therapy, there's already a precedent set for multiple HIF2 inhibitors or combinations thereof of TKIs. With that, thank you very much for your attention.
Wow, Ty, this was a tour de force, and I congratulate you for making new slides, all new slide using BioRender. So I don't know, I know this is 12 minutes, but I don't know how much you spent on this talk, but must be. Yes, yes, yes. No, it's well worth it. I'm gonna ask for those slides. Okay, and last but not least, Dr. Vincent Zhu from Dana-Farber Cancer Institute, my colleague. Vincent has been involved very much so since his fellowship in biomarker in kidney cancer, and is a testimony for funding, for the DoD funding, as he is part of the DoD Kidney Cancer Academy. Vincent?
All right, thank you, Toni, for the introduction, and thank you for the chance to talk on essential biomarkers in RCC. I have to say, I also love BioRender, except instead of paying, I just use Toni's account. Anyone from BioRender here, just feel free to bill Toni. Here are my disclosures. Biomarkers in RCC, as you've heard from so many of our speakers, are an unmet need. We need better guidance to make clinical decisions. We need to understand, for someone who doesn't have kidney cancer, as you've already heard from sessions yesterday, we need to have a better understanding of who should we be screening for kidney cancer. For folks with localized renal masses, who needs surgery and when do they need surgery? For patients who have their tumors removed, who needs adjuvant therapy and who needs intensified adjuvant therapy, while some people may not need adjuvant therapy at all. And in the metastatic setting, not all patients may need systemic therapy right away, And how do we give the right treatment to the right patient at the right time? These are all questions that we could do better if we had effective biomarkers. I have the real benefit of coming after many of our speakers, and you've already heard a lot about biomarkers in kidney cancer. As you know, we have now a much better understanding of RCC biology based on our ability to interrogate the tumor, the microenvironment, and the host. And in fact, we now have a plethora of ways to understand kidney cancer better. Now, I'm not going to spend the next 8 minutes summarizing all of these biomarkers because, in truth, I can't, and others could do it better than me. Fortunately, many folks during this meeting have already done a great job of doing this, and you've heard already about cell-free DNA, novel imaging, some other novel checkpoints, somatic mutations, circulating cytokines. You've heard about KIM-1 and others as well. And so instead, I'm hoping to use this time to take a few case studies and also to think with you together about how we can move the field forward and what the future of biomarker development might look like and how we can make this more clinically relevant for our patients. As you've heard yesterday, including seminal work initially largely by Dr. Marston Linehan and now others, tumor mutations are drivers in clear cell RCC. The truncal mutation for clear cell RCC are alterations in VHL, but adjacent genes to VHL on the short arm of chromosome 3, including PBRM1, SETD2, and BAP1, also play crucial roles in clear cell RCC tumorigenesis. And while over the years our understanding of these driver mutations has really become much better, nonetheless, unfortunately, when we look at the presence of these drivers in our phase 3 clear cell RCC trials, their presence or absence still does not seem to clearly tell us who to give which treatment to for our patients. As a second example, we have now more and more information about gene expression signatures in RCC. And again, as you've heard already, some of these transcriptomic signatures are derived from RCC trials directly, and others are tumor-agnostic signatures for immunotherapy response, for example. And we also have emerging signatures for T cell dysfunction and NK cell dysfunction, specific segments of the tumor. These signatures tell us a lot about tumor biology, and it's clear based on our analyses from phase 3 trials led by many of the physicians in this room that there is certainly predictive signal for these signatures. For example, angiogenic RNA signatures clearly portend a better response in some patients to angiogenic therapies and better response to immune therapies for proliferative or T effector signatures. However, whether these signatures actually should guide pre-treatment our treatment decisions remains an open question, and this question is being investigated by folks here in ongoing trials. As a third example, PD-L1, biologically, PD-L1 makes so much sense. We have PD-L1 inhibitors, they bind to PD-1, we just test the ligand, and if it's there, it works, and if it's not there, it doesn't work. Unfortunately, that's the complete opposite of what we've seen in our phase 3 trials. And despite kind of the biologic neatness of that story, what we've seen in RCC trials consistently is that the clinical benefit from immune checkpoint inhibitors is not limited to patients with PD-L1 expression. And so unfortunately has really not panned out as a way to make these decisions. And it's really frustrating, right? When we meet a patient or when we're talking to a patient about what their goals are, patients have goals that are important to us and more importantly to them. Patients want quality of life, patients want survival, patients want response to treatment, and often, when possible, patients want cures. So these are the things that we're really striving towards. We want patients that have healthy, normal lives. But on the other hand, what do we offer patients? A PD-L1 test. And there seems to be a very far distance between what we have and where we need to be. And, again, when you look at the diagram in a textbook or on BioRender of how PD-L1 works, why don't we get there? Well, when we look at what happens when we get a PD-L1 test, of course, as you all know, we're measuring a slide with an IHC from a nephrectomy sample that was taken maybe 10 years ago, using only one part of the tumor, using one of several PD-L1 assays, all of which are imperfect. And so when we think about all the other things that are really crucial in helping to understand the living system, which is what a patient is, there is a lot else that goes into it. Some of these things we can measure and that we are getting better at measuring, and some of these things we are not very good at measuring. On the road between a PD-L1 binding and a tumor response and a cure, there's the tumor stroma, there's gut bacteria, you heard about soluble MADCAM, there's gene transcription, protein expression, we heard about KIM1, tumor heterogeneity, mutations. Beyond mutations, there's epigenetic regulation of transcription. There's environmental exposures. Does the patient have someone who smokes heavily in the home? Is the patient driving 3 hours each time he comes to clinic for an infusion? These are things that impact outcomes. There's the immune microenvironment, and there's other comorbidities. So this is really overwhelming. And when I think about this, I have a 20-minute follow-up visit with a patient. Can I understand all the interactions between these factors in that 20 minutes and integrate them into my decision with the patient? And clearly the answer is no. But fortunately, my 1-year-old had an answer. And he has this book called Neural Networks for Babies. And in this book, there's a very nice diagram. It looks something like this. You know, you have a bunch of data. Those are your inputs. You don't really care what happens in the middle. Some stuff happens. Science, calculations happen in the hidden layers. And then you get an output. So we have these tools now that we didn't have before that let us process extremely complicated data and hopefully leverage the complexity better. And I hope that in the future, you know, while it's still important to understand single biomarkers, and very much so, you know, perhaps KIM1 can help us make some clinical decisions, I think the future will be in these, leveraging this complexity and being able to use it without getting overwhelmed by the interactions. And we've already seen that some folks in this room are making great progress in that direction. And so I was really impressed by this talk by David Braun at ASCO just last month, where using integrated data streams from the Checkmate 9ER randomized trial, including tumor biomarkers, AI analysis of IHC slides, peripheral blood biomarkers, incorporating all these biomarkers together in an AI model, we were able to make better predictions about patient outcomes compared to any individual biomarker on its own. And so these calculations don't have to be made in the clinician's head. There are now models that we can build that can help make these predictions. And to give another example, you know, recently through collaboration with a proteomics AI company, OncoHost, we've been measuring samples from many hundreds of patients using their clinical data integrated with over 7,000 circulating proteins based on the circulating SomaScan assay. And using AI models, we can build predictors using this one data set, clinical data, outcomes, medications, 7,000 protein measurements, and we can build, using the same underlying data, different models for different outcomes. We can build a model for IO toxicity. We can build a model for sites of metastasis. We can build a model for response to immune checkpoint inhibitors or to VEGF TKIs. And for more details on some of these models, I invite you to check out some of these abstracts which are referenced. Now, these models are inherently models that need to be validated in clinical trials and in prospective data to be used clinically. However, I think they give us some sense of the direction that we could go, where we can really start leveraging all the data that we have from different data streams to help patients. And one of the key bottlenecks for this moving forward is really going to be data accessibility. You know, now we have such rich data sets from many of our phase 3 trials, and I really applaud our industry collaborators for collecting this data. However, right now as the data sits, largely the data is siloed in the individual trials. I think as we have these really powerful computational tools, if we're able to share data between investigators, I think it will really help us all to move forward. In summary, I think biomarkers are a lot of work, but they will reduce both overtreatment and undertreatment. Dr. Haas brought up adjuvant therapy in RCC, which I think is a great example. We know from Dr. Choueiri's trial, Keynote 564, that patients have overall survival benefit from adjuvant therapy. Right now, as it stands, that survival benefit, which is very, very real, is being driven by the very middle of this graph. But there's a lot of space to explore in this graph, and we can do better for the patients who need more treatment, and we can do better for the patients who need less treatment. And I think we can do better to help find out who these patients are. So with that, I want to thank again all my colleagues and mentors, Dr. Choueiri, Dr. McDermott, Dr. Romy, Dr. Viswanathan, Dr. Signoretti, Dr. Lisa Hensky, Dr. Braun, Dr. Haas, Dr. Powell, Dr. Dicker. So many people were working together on these biomarkers, and I think the collaboration is really what I value from this group. And so thank you so much for your attention.
Great talk. We have till 10:10, and after 10:10 we have half an hour coffee break. So we have around 10 minutes for Q&A. So we're gonna start little by little. We're gonna pick on people that gonna raise their hand and have not spoken yet. There are people that ask question, 2 questions in each session, which is fine, but that will let other people not ask questions. So I'm gonna start in the back by Dr. Brugarolas, who's standing for an important question.
So Bob, one of the things that you mentioned, or one of the questions that you finished with, was about belzutifan. And I feel like obviously there are a lot of studies looking at combinations, because this is a very well-tolerated drug. But it is also great quality of life for our patients when they are on single-agent belzutifan. So I feel that, maybe personally, I feel like it's a pity that we are not exploring, I don't know how to do it exactly, belzutifan as a single agent earlier, where it could be given patients better quality of life for a more prolonged period of time.
Do you want to take this?
So that's a great question. I mean, I think as we touched upon, where's the best place to put belzutifan, right? So I think certainly for VHL patients, it's approved, and in the setting of metastatic disease in the U.S., it's really third-line therapy or people who have progressed on a TKI. So I mean, I'd like to see it moved up earlier, and certainly, but I think we need evidence that it's, say, better than TKIs before we replace TKIs with belzutifan.
I think in addition to that, there's at least one trial that looked at it a little bit sooner. I think it was LightSpark 013, is that right?
Correct.
Mike and Niraj and others looked at that, and that actually showed it when you had less VEGF exposure, the drug might be more active. So that suggests if you maybe did it after just IO, it could be even more active. So that seems worthy of exploration.
And there are other HIF2 inhibitors that are using in a selected cohort single agent HIF2 inhibitor. The problem, we don't know how to select, and when you have over 30% PD as best response, we know that patient will be able to receive, unfortunately, less therapies with time.
Well, we don't know yet how to select, Tony, but we will know.
We will know.
Yes.
Yeah,
You're
hopefully.
working on it.
We're working on it.
Yes.
So far, 0 out of 2 with
okay,
TKI and PD-1.
Okay.
We
I
will.
think there's
Naomi?
a trial under development in the KCRC for favorable risk that's observation versus belzutifan.
Yeah, well, observation quality
Or
of life
versus
is
a
good.
HIF.
I'm going to ask Laurence because she wanted to ask. Thank you. And then you.
Okay, thank you, Tony. Great session. So my question is actually for Ty. There are 2 classes of drugs you haven't commented on, which are ADCs. And the second one is like 10 years ago, you were pioneer with regard to histone marks and so on. Where we stand in terms of targeting the epigenetic itself?
Sure. So those are interesting questions. With antibody drug conjugates, they all come in similar flavors of the same payload. We haven't really moved the needle in terms of payloads. Payloads are usually MMAE, topotecan, exatecan. They fall in the same class, and traditionally, these payloads haven't been that effective as naked molecules. So the hope with antibody drug conjugate is that you have increased endocytosis, you expect a 30 higher fold excess inside the cytoplasm, but at least for some of the ADC data that I've seen so far, the response rates have been fairly modest. So this may suggest that either the linker payload isn't that effective for at least clear cell, because we're using agents that are essentially the same class, the vedotins, the exatecans. With regards to targeting some of the epigenetic machinery, we did publish a synthetic lethal paper looking at SETD2 mutations. Others have also published stuff. But we've had basically negative data once we actually take into patients, probably the most prominent being the WEE1 kinase combination. And I think that has to do with the heterogeneity of the tumors. So not all the tumors contain the same mutation, and I think it makes it very difficult to tolerate. And then the other addition is when you target epigenetic machinery, it often targets the PBMCs and the stem cell population, so they end up having a lot of myelosuppression. So it just makes it hard to develop as a combination partner going forward.
Hans is itching. Hans?
Sorry to get back to the belzutifan biomarker quality of life issue. So I actually don't see necessarily the combination as the enemy. I think it's an opportunity and a potential pathway to identify patients safely who may benefit from belzutifan monotherapy. That means we could have an adaptive approach. We take the deep responders to len-bel and drop the lenvatinib and see if they can ride on belzutifan alone. I think that's a very safe pathway when we don't have biomarkers.
I'm gonna counterpart a bit, and I say, in theory and in preclinical and animal model, this is beautiful. When we try to apply it, it's impossible. Look at pedigree, the PD of best response, and the patient that were not able to move from step 1 to step 2. It's very simple. Nivo-IPI, based on your response, you move. 30% of people came off. They just cannot. We have Bob's study, record 2? 2. 1 and 3.
Record 3.
4. 3, sorry. I mean, record 3, where sunitinib, everolimus, sunitinib. Yeah. 40% of people just get lost.
No. So I meant the combination of len-bel. PD rate is 5%. Everybody starts on len-bel. The patients who get a nice response confirmed, they drop the lenvatinib and continue on just belzutifan. You would expect that roughly 50% of those patients would do well on belzutifan alone.
That's possible, but I think, again, in practice, we have very similar-ish, not the same example where after a while, if the combination works, a patient and even a physician will feel uncomfortable stopping. We have it with PD-1 inhibitors. So I think it's an important thing to do, but the joint experience the past few years, clinically, we haven't been able in a trial to execute. I mean, that's my personal opinion. Not that it shouldn't be done. Let me see. Anyone? Monty, please throw it.
Thanks a lot. Great talks all around. My question is for Asim and Naomi. Asim, I'm highly supportive of your ECOG trial design. I think it's the right one to address the non-clear cell population. Just out of curiosity, I was just wondering if you kind of quickly walk us through the evolution of that design, because I remember originally it was IO plus or minus TKI. And then again, if you just kind of quickly comment on how we can sort of challenge existing, sort of dogma in that space, because I think that people have strong feelings about, the relevance of IO and that subset as adjuvant therapy already, either for or against.
No, excellent question, Monty. The original design was 3-arm, but unfortunately we couldn't find a VEGF in the CTAP. That was the reason why, the previous design couldn't move forward, and then we end up dropping that arm.
I see.
But I think still that question is a valid question, and I think when we talk our patient advocacy groups, yes, TKI is good, but at the same time, come with cost, which is side effect. And we know that PD-1 alone is quite well tolerated, and I think this is gonna be still an important question that we need to answer. If it is positive, then that will set the stage for future trials. If it is negative, then we still set the stage for future trials. But that was the main reason why we changed the design.
I agree, and I mean this process is a bit painful, but it's as democratic as it can get. We have one question before, and I think David Brown wanted to ask an important question about all these biomarker integration from his oral at ASCO.
I was actually going to ask a non-biomarker question.
Okay, I expect, but comment on that and please ask your question.
mute. 214.
I still try to look and see if it can be cut out.
Yeah, I also do a lot of surgery, David, a lot of local therapy, SBRT, ablation. And then if I need to start systemic therapy, I tend to use more Pemlan first line and then move on.
Bob?
Well, I think, you know, for the most part, most of them have a very indolent history. So to Naomi's point, a lot of patients I don't treat initially. I follow them, and I mean, I have patients I've been following for 10 years with minimal growth of their chromophobe tumor. You know, the flip side of that is sarcomatoid chromophobe tumors, which really have the most aggressive downhill course. In general, for systemic therapy in the past, I mean, everolimus actually looked better than Sutent in that one population. And in the lenvatinib everolimus phase 2 trial, although there were only 4 or 5 patients, there was activity. So I used to use lenvatinib everolimus in that population, but I think based on the len-pembro data, I now treat those patients with len-pembro. I think actually len-pembro is better tolerated than lenvatinib everolimus in most of my patients. So that's what I've gone to.
David?
I'm not sure I have anything to add. What Bob said, how about that?
I love that. Ty?
Nothing to add. Surgery and then len-pembro if I can.
Yeah, I would agree with all of that. I think, you know, Dr. Motzer brought up a great point, which is sarcomatoid features. And Dr. Chris Labaki presented data before that, you know, in non-clear cell with sarcomatoid features, they may still be enrichment for immune response. So I think that's the population where I would consider possibly ipi-nivo if they weren't too symptomatic from their disease. Otherwise, I think len-pembro for most patients.
David?
I think the data shows we need new targets, so we need to support translational
Yes,
research.
thank you, David.
Dr. Hensky.
Absolutely.
Grants.
KIT antibody drug conjugate. Absolutely.
That's worth a test.
I
Based on what we
do surgery unless it's rapidly progressing, and I think len-pembro, and I would say that I was very surprised by the German trial, the activity of 24% in nivo-ipi, but I understand that the German trial is going to look at chromophobe only because they're centrally reviewed, and look at nivo-ipi in chromophobe. I think we deserve that, or they deserve that, see if they have sarcomatoid or what. So thank you very much.